So I hope it's last not the least. And thank you, Bhavna. Thank you, Dr. Pramesh and eCancer for having me here. Here are my top 10 choosing wisely for India and gynec malignancies. So let's start with prevention and screening, and I'm going to keep it really short and hopefully sweet. Uh, Although cervical cancer incidence has decreased, as we saw in the morning, quite substantially, it still contributes to over 120,000 new cancers. This was Globocan 2020. The same year, it accounted for 77,000 odd deaths, which make up about 9% of all cancer deaths seen in India. Screening for cervical cancer is not practical, it's not feasible, and population-based screening is really out of the question. So this study that we have shown you evaluated the impact of visual inspection with acetic acid or VIA on cervical cancer mortality. You had two cohorts which were recruited to this planned 16-year study. Both had access to cancer education, but only one was additionally followed with 4 rounds of VIA. The take-home message was that VIA saves lives. The age-adjusted mortality rate per 100,000 women years with VIA was 14.4 instead of almost 20 without the procedure. And this translated into a 30% reduction in the risk of death. This made the headlines of the plenary in ASCO in 2013, and this was also followed by a publication in JAMA. And estimates are that this simple procedure could almost save 22,000 women a year in India alone. The next is basically on prevention, and we know that the cervical vaccine does help against persistent HPV infection, at least for 16 and 18. And this was a study done at 10 years where they looked at 1, 2, and 3 doses of quadrivalent HPV vaccine in girls in India. So basically in this randomized trial, girls which were between 10 and 18 were recruited from 9 centers across the country and randomly assigned to 2 or 3 doses. There was a problem and a suspension of recruitment, and the study then became a prospective cohort study by default. And participants were based on the number of vaccines they had received. They were either a 2-dose cohort, or they were a 1-dose cohort, or a 3-dose cohort. The participants were followed up yearly and cervical specimens were collected. And the findings were that you had almost over 4,000 odd patients who had 3 doses, another 4,000 had 2, and another 4,000 over had a single dose. And vaccine efficacy against persistent HPV 16 and 18 amongst the participants evaluable for the endpoint for 1 dose was 95.4%, and for 2 doses was 93%, telling you that there was absolutely no difference. And a single dose of HPV in a country like us, if you are considering vaccination, really is equivalent, and the patient gets or the person gets protection against the 2 main genotypes, 16 and 18. Let's go on to surgery. So there's been a lot of hype about HIPEC, and this has also been discussed in other malignancies. The question is, we know from a randomized phase 3 trial that HIPEC has shown an overall survival benefit with a hazard ratio of 0.67 in the interval debulking setting. But the additional cost has been quite prohibitive, almost $1,800 to $3,500. And this is mainly due to the consumables and the machine that is required. So can we develop indigenous devices? Yes. So there is a lovely study with Butt, which has described a homemade HIPEC machine, which has been fashioned from a cardiac bypass machine. And this has brought down the cost from $2,000, which is 1.6 lakhs, to $450, 36,000, making it more affordable. The second, again, following the theme of other malignancies that we've already talked about extensively, is robotic surgery. So robotic surgery for endometrial cancer as compared to open or laparoscopy. We know that costs are 20% higher, and this is for a gain of 0.18 QALY at 6 weeks of surgery. The total cost of robotic surgery can vary from $9,000 to $17,000 In India, the additional cost for robotic surgery is $1,250 to $1,800. That is 1 to 1.5 lakhs per patient. I suspect it may be more compared to laparoscopy, which is 50,000. Plus the cost of the robot, the annual maintenance cost, the disposables. And what has been shown, and I think we need to really consider this, there is essentially no difference in patient outcomes between laparoscopy and robotic surgery. Coming now to radiotherapy. So this is a very, very simple thing that we can follow. Wherever there is no imaging available in the smaller towns, we know that the FIGO staging system does not really consider CT-MR mandatory, though the use of these modalities have been encouraged. Most cervical malignancies can be diagnosed and staged with a good clinical exam, and in a setup where you don't have access to imaging facilities, a treating oncologist can get away with a good clinical exam and plan patients for radical chemoradiation. What about treatment of early endometrial cancer, stage 1A and 1B? This is highly controversial, and there are a lot of aspects to it. So we base our treatment on risk stratification, which helps us avoiding unnecessary pelvic radiation. We know that intermediate risk cancer requires some sort of brachytherapy, but we must remember it's further divided into low and high risk. That is intermediate risk. And these are all the definitions of intermediate risk cancer. And these patients should be getting only vaginal brachytherapy. The question then arises, is there a subset of these patients that require pelvic radiation as well? And if we look at the further refinement, so there are 3 different risk factors described above, and depending on the age criteria, if a patient is over 70 with 1 risk factor, patient is between 50 and 69 with 2, or patient is below 50 with all 3, then this patient may benefit from adjuvant EBRT, and that needs to be discussed. So we come now to a trial that was done at the Tata Hospital itself. So this is the value of adding neoadjuvant chemotherapy followed by surgery versus concurrent chemoradiation, patients with stage 1B2, 2A2, or 2B squamous cell cervical cancer randomized trial. Over 600 patients were randomized and included in the final analysis of a follow-up of almost 6 years. And the 5-year disease-free survival in the neoadjuvant group was 69% versus 76% in the combined chemo-rad, and there was no difference in overall survival. So the authors concluded, and I think this is great because a lot of people like to downstage with chemotherapy first, and the oncosurgeon then likes to go in for surgery. But this trial has conclusively shown us that you don't need to waste time with unnecessary neoadjuvant chemo. And in these stages, you can happily opt for chemoradiation, which gives you a superior disease-free survival. Let's turn our attention to the last one, that is systemic therapy. The question is here, should be using PARP inhibitors in first line as maintenance in advanced high-grade serous ovarian cancer in our country. So we have a host of data. We have a host of PARP inhibitors. Olaparib came first. It is available, but it is rather expensive. And then we have our own generic and biosimilar rucaparib, which is available at a slightly more affordable cost. And as you can see from the data here, the results are more spectacular for olaparib in the germline BRCA mutated, whereas the hazard ratios are slightly higher for all comers. So the best value for money in your patient is for a germline or somatic BRCA positive patient. You're going to get a difference in PFS over years, and that's where you're really going to get the largest benefit. The second largest benefit, however, is seen for HRD positive patients. Now, this was another IPD meta-analysis which was done by the Tata Group, and it was published, I think, a couple of months ago. And what they showed was maintenance PARP did result in a significant PFS improvement, but it varied according to subgroups. And the PFS gain was largest in the BRCA mutated. No significant benefit was seen in the HRD negative group. And I think that's where we should focus on. The olaparib bevacizumab data, overall survival is negative. The overall survival for SOLO-1 was presented at ESMO last week, and it showed that at 7 years of follow-up, over 75% patients on olaparib were alive compared to 46% on placebo. And I think this is a great benefit. So across all groups, like I mentioned, BRCA positive and HRD positive, there is a benefit. The last two points that I'm going to discuss is on immunotherapy. So should we be using IO for all recurrent metastatic platinum-treated cervical cancers? The treatment of metastatic recurrent cervical cancer has really been disappointing. We've had some new data from IO in cervical cancer, and pembro has now been recently approved with chemotherapy and or BEV in the first line. And the benefit is about 6 months in overall survival. And the maximum benefit has been shown for these PD-L1 positive patients, and it has to be restricted to this group of patients. Even then, a cost-effective analysis has been performed not in India, but in the US, and is shown for this population, the addition of pembro was associated with an increase of only 0.74 QALY. And this came at an additional cost of over $182,000. So I think you've got to keep all this in perspective of whether you're going to use taxane platinum with or without BEV, with or without immunotherapy. The last point I'd like to stress on is what about recurrent or metastatic platinum-treated endometrial cancers? So there was this great publication from the Memorial Sloan Kettering group, and both pembro and dostarlimab have been approved, but the response rates, PFS, OS are largest for those with MSI tumors. Since we are routinely testing endometrials for MSI, my contention is that keep immunotherapy for this group, again, where you get the most value for your money and the most clinical benefit as well. There's only one phase 3 for pembro lenvatinib, and for my colleagues who've given this combination, they know how toxic lenvatinib is with pembrolizumab. And this has shown a benefit in the MSS group, the OS benefit of the intention to treat of about 7 months. But the cost effectivity studies done again in the West show that it's not cost effective. The combination gave an additional 0.64 QALY at an increment cost of over $241,000 compared to chemotherapy alone. So my sincere request, all these treatments, when you consider IO in both endometrial and cervical cancer, they have to be used very judiciously. Thank you.